Hello, everyone. Welcome to our Zoom meeting. Today we will have the team presenting at least 3 topics. So Dr. Muram will be leading the Zoom meeting. Hand it over to you, Dr. Muram, when you have a minute. Hello. Thank you so much. Go ahead.
Okay. Hello, Dr. Nader again. Hello, everyone. My name is Muram Abdelmagid. I'm a Lyme team leaders, and also will monitor the meeting for today. Today, let me first share my screen. Can you see my screen right now?
Yes, we can see it.
Sorry, Dr. Nader, I couldn't hear you well.
Yes, we can see it.
Hello? Can you hear me?
Yes, we can hear you.
Yes, we can, Dr. Muram, go on. Yes, we can hear you.
Okay, perfect. So for first topics, we have we have hematology in older adults. Inshallah, we will present this topics with Dr. Eithar. Dr. Eithar, if you're ready, go ahead.
Yes, thank you, Dr. Muram. Hello,
I will
everyone.
open.
Hello, Dr. Nader. Okay, open. I am Dr. Eithar, an IMG from Sudan. Okay.
Can you see my screen, Dr. Eithar?
Yes, thank you very much, Muram.
Okay, go ahead.
Okay. Welcome to our exploration of hematology with the focus on the older adult population. As we age, our hematobiotic system undergoes significant changes, affecting everything from blood cell production to the management of various blood disorders. In this session, we will uncover how hematopoiesis evolved with age and dive into the classification and workup of anemia. We will also guide you through identifying and managing common issues like thrombocytopenia, thrombocytosis, and qualitative platelet problems, and as well as complex clotting and bleeding disorders. Additionally, we will examine myelodysplastic syndrome and the chronic myeloproliferative neoplasm, providing comprehensive overview to enhance your clinical practice. So join us as we navigate the critical aspect of hematology in older adults. Next slide, Muram. Next slide. Yes, the next one. First, I will discuss hematopoiesis and hematobiotic stem cells in detail to provide a foundational understanding of hematology. Next slide, Muram. Okay, thank you. Hematopoiesis is the process of blood cell formation, which is essential for sustaining life by ensuring an adequate supply of red blood cells, white blood cells, and platelets. The hematobiotic stem cells are the key players in the system, with the unique ability to either self-renew or differentiate into the various blood cell types. The regulation of this process is critical for maintaining blood hemostasis, ensuring that the body has the right balance of red blood cells, white blood cells, and platelets. hematopoietic stem cells give rise to two major progenitor cell lines. The first one is a myeloid lineage, and this gives rise to red blood cells, platelet, and most type of white blood cells like neutrophil, eosinophil, and basophil, monocytes, and macrophage. And when we come to lymphoid lineage, this gives rise to lymphocytes like T cells, B cells, and natural killer cells. The differentiation process is tightly regulated and irreversible, meaning that once a progenitor cell commits to a lineage, it will continue along that path toward maturation into a specific cell type. Hematopoiesis is regulated by a complex network of signals between hematopoietic stem cells and their surrounding stromal microenvironment in the bone marrow. These microenvironments include various support cells like stromal cells, endothelial cells, and also extracellular matrix components and regulatory molecules like growth factor and cytokines. For the body to function properly, the hematopoietic system must maintain a balance between producing new blood cells and removing old or damaged one. Next slide. Studies in mice showed that with hematopoietic stem cells demonstrate first reduced ability to regenerate the hematopoietic system and decreased ability to generate mature lymphocytes. So in contrast to the reduction in lymphoid input, aging hematopoietic stem cells show an increased propensity for myeloid differentiation. This results in an overproduction of myeloid cells, such as granulocytes and monocytes, and so on, relative to lymphoid cells. This shift toward myeloid lineage is often referred to as myeloid skewing, and it is an inherent feature of aging hematopoietic stem cells. The myeloid dominance of adult human lead to first higher risk of myeloid malignancies like acute myeloid leukemia or myelodysplastic syndrome. Also, secondly, decline in immune function. So, as I said, the myeloid dominance. So, as I said, the myeloid dominance of adult human leukemia may be driven in part by first age-related deficient lymphopoiesis and development of myeloid clones. Next slide. Now that we have a solid understanding of hematopoiesis, let us proceed to discuss anemia. Anemia is the most common age-related hematologic abnormality, particularly prevalent among older adults. According to the World Health Organization, anemia is diagnosed when hemoglobin level fall below 12 grams per deciliter in women and 13 grams per deciliter in men. The prevalence of anemia increases with age, affecting approximately 10.2% of women and 11% of men over the age of 65. And this rate climbs even higher on those over 80 years, with up to 22% of men being affected and up to 16% of women being affected. Despite through evaluation, the exact cause of anemia in many older adults remain unexplained. Okay. Next slide. Anemia in older adults is not just a lab finding. It carries significant clinical implications. First, decrease in cardiac output. Second, local tissue hypoxia. Third, aggravation of comorbidities and also functional declines. Importantly, anemia is linked to impaired mobility, with older adults experience diminished performance in activities of daily living. In fact, studies have shown that women over 65 with hemoglobin level below 11 grams per deciliter have a higher risk of all-cause mortality compared to those with the level above 12 grams per deciliter. And this risk persists independently of comorbidities. Physiologic classification of anemia. The next slide, Muram. Okay. How to classify anemia? Hypoproliferative anemia and the possible causes of it: iron deficient erythropoiesis. This results from iron deficiency or chronic blood loss. Erythropoietin deficiency, and this caused by renal or endocrine issues leading to insufficient erythropoietin production. Stem cell dysfunction include conditions like aplastic anemia, where the bone marrow fails to produce adequate blood cells. Ineffective erythrobiosis possibly causes macrocytic anemia associated with vitamin B12 deficiency, folate deficiency, or myelodysplastic syndromes. Microcytic anemia caused by conditions like thalassemia or sideroblastic anemia, and normocytic anemia. This seen in myelodysplastic syndromes where red blood cells are of normal size but are produced inadequately. Hemolytic anemia may be due to immunologic, and this includes idiopathic or secondary autoimmune hemolytic anemia. Intrinsic causes due to abnormalities in hemoglobin or metabolic process. Extrinsic, caused by mechanical destruction of red blood cells, like mechanical heart valves. Next slide. Evaluation of anemia. When hemoglobin levels are between 12 and 13, the approach to evaluating anemia should be guided by clinical judgment. What we mean by that? We mean by that the decision to make further evaluation depends on the patient's overall clinical pictures, symptoms, and comorbidities, and factors such as age, existing health condition, and symptoms play a role in determining the need for an aggressive evaluation. The principles of evaluation remain consistent regardless of the patient age. These principles include assessing for potential cause of anemia and understanding the patient's overall health status. The evaluation should focus on identifying the underlying cause of anemia, which include blood loss, destruction of the blood, production deficit, destruction of the blood, or combination of these. Analyzing the morphology of red blood cells and red cells in dyes, such as mean corpuscular volume, MCV, can help with the classification of anemia and evaluation. Next slide. Also, platelet and white BCs count can help distinguish an RBC's lineage problem from a broader underlying bone marrow process. When to consider bone marrow biopsy. Generally indicated if a morphologic and laboratory evaluation are inconclusive, and there are abnormalities in two or more cell lines like RBCs, platelet, and white BCs. And when bone marrow biopsy is considered, it is advisable to refer to hematologist for comprehensive evaluation. Okay. As with platelet and white BCs count, also an absolute reticulocyte. Next slide. Okay. Absolute reticulocyte count helps confirm the presence of appropriate bone marrow response. A lack of reticulocytes, from after hormonal or toxic or infections etiologies have been excluded. This should trigger a review of a peripheral smear to assess for morphologic feature suggesting marrow failure. Okay. To continue with the evaluation of anemia, let's talk about hemoglobinopathies. Are a disorder caused by abnormalities in the hemoglobin molecule, which can affect the assembly and function of red blood cells. These conditions are typically inherited but may not be diagnosed until later in life, especially if symptoms are mild or not evident until older age. Etiologies, qualitative abnormalities like sickle cell triad or disease, and quantitative abnormalities like thalassemia. Diagnostic signs, abnormal MCV or alteration in morphology of RBCs on the on the peripheral smears can indicate hemoglobinopathies such as sickle cells, and this seen in sickle cell disease, or target cells, and this seen in common seen in thalassemia. Hemoglobin electrophoresis is generally used for diagnosis, although identification of sickle cell triad requires genetics testing. Next slide. Okay, to continue with the evaluation of anemia, acquired assembly defect in hemoglobin production, one possibility is the toxin, such as a lead poisoning. Another possibility is the lack of iron or vitamin B12 or folic acid or copper. It is important to differentiate between deficit of intake and a deficit of absorption. Acute illness, medication, and toxin can interrupt RBC's assembly, resulting in the clinical and laboratory picture of anemia of chronic disease. Next slide. Okay, to continue with the overview of iron deficiency anemia. It is diagnosed by the presence of, first, decreased serum iron, second, decreased transferrin saturation, and three, normal or decreased serum ferritin concentration. Iron deficiency anemia can be treated with either parenteral or oral iron. IV administration is indicated in patients receiving an erythrocyte stimulating agent during dialysis, or if the use of oral iron preparation is unattainable. This choice of IV agent is based on the patient's allergy history and the length of infusion course desired. Consider evaluation for blood loss from GI tract or GI tract or female reproductive tract. Next slide. Okay, Dr. Gaffer will continue from here with the evaluation and treatment of possible iron deficiency anemia. Thank you, Dr. Muram.
Okay. Can you guys hear me?
Yes, go ahead.
Thank you. First of all, thank you, Dr. Eithar. My name is Dr. Gaffer Ahmed. I'm a graduate from University of Khartoum. To continue with the evaluation and treatment of the possible iron deficiency anemia, we have here a graph of the steps to follow. First of all, we obtain, just like what Dr. Eithar said, the serum iron studies in serum ferritin and serum iron and the serum iron, the transferrin saturation. After that, we can see in which bracket does the patient fall. First of all, if the serum ferritin is less than 30 and the saturation is less than 20%, this is most likely iron deficiency anemia. From there, we have to evaluate for the causes of the iron loss, whether like what she said, GI or GU. And then after that, I will start with iron therapy and check for response. If there is any response to iron therapy, will most confirm the iron deficiency anemia. If we have a serum ferritin of 30 to 100 and a transferrin less than 20%, this is a possible iron deficiency. This is borderline results, so I will start with an iron therapy and check for response. If there is any response to the iron therapy, as I said, this will confirm the iron deficiency anemia. If no response, this will lead to further diagnosis. And the diagnosis can be either anemia of chronic disease, or an undifferentiated anemia of elderly, or a myelodysplastic syndrome, which we will show a lot of details soon. If the serum ferritin is more than 100 and the transferrin is less, saturation is more than 20%, This recalls for an estimation of the GFR to assess for the kidney function. Furthermore, if the kidney estimated GFR is less than 60, this is most likely a problem with the kidney and a deficiency of the erythropoietin. This is a chronic kidney disease and recalls for a management of erythropoietin stimulating agent. If, however, the GFR is more than 60, here the cause of anemia is most probably vitamin deficiency, and we evaluate for another causes which are B12 and folate. After excluding the folate and B12 as the cause of anemia, here I will be left with the same three reasons, which are myelodysplastic, the undifferentiated anemia of elderly, and anemia of chronic disease. So for the evaluation of iron deficiency anemia, I will start with the serum iron studies, and then from there I will according to the result I will guide my management. Okay, next slide please. Okay, regarding the oral iron supplements, the oral route is always the preferred first line therapy. In regards to the type of preparation, there has been no significant differences amongst the preparation among the different preparations in regard to either the efficacy or the adverse profile. Okay, for this adverse effect, the most recorded side effects are the mild nausea and constipations. Generally, the ions that ion containing 15 to 20 milligram of iron, as we said, with either preparation like ferrum gluconate or sulfate or whether may be better tolerated than a higher dose preparation, as we said, because of the adverse effect of the nausea and constipation. Other routes like an ion elixir and liquid ion may be better absorbed than the tablets. Overall, the treatment with oral supplementation for iron deficiency anemia must be at least continued for a period of at least 6 months or more. Okay, next slide. Now, moving on to the different causes of of the anemia of inflammation. We start with anemia of chronic disease. Anemia of chronic disease is a constellation of multiple factors like morphological, laborotic, and clinical feature, which reflect the process of a disease. In anemia of chronic disease, the hallmark is that due to the ongoing inflammation, there is increased level of ferritin, which acts as a acute phase reactant. This leads to sequestration of iron in the ferritin and decrease iron for the RBC production. So the hallmark of anemia of chronic disease is the increased ferritin, normal to increased ferritin, plus a decreased serum iron, as we said, due to sequestration, and the transferrin level and iron saturation will all be also decreased. In regard to the bone marrow is functioning all well. That's why we will find normal erythrocyte precursor with an increased storage of iron, as we said, because the iron is trapped within the ferritin. Always we should consider measuring the ESR and CRP, which are markers of the inflammation. Next slide, please. Okay. Whenever we find a hemoglobin less than 10, we should consider a multifactorial causation, including the blood loss and malnutrition or hemolysis. In these circumstances, because of the multifactorial causes, the lab findings may not be may be equivocal and not leading to a particular cause. So that's why in circumstances like this, a bone marrow examination may be required. In cases like this, we always have to use our clinical judgment in deciding how aggressive the evaluation might be with regard to that, as we said, the bone marrow examination. Anemia of chronic disease, as we said, the treatment is directed toward underlying disease because there is actually no problem with the production of the RPCs. So with dealing of the underlying disease, most probably the anemia will resolve. There is evidence that patients with profound fatigue may benefit from a transient from iron infusion, and some patients respond to erythropoietin replacement therapy. All of that after treatment of the underlying disease. Next slide. Okay. The other cause that we talked about is mono failure. Of course, bone marrow failure is a broad term, and causes include many, like medication, immune damage, infection, or malignancy. The cause that is often missed is multiple myeloma, which is a plasma cell dyscrasia, which should be always included in differential diagnosis because it's a disease most commonly affecting the elderly, and it might present with signs of features of anemia. Also, we have a pure red cell aplasia, which is isolated suppression of erythrocyte. The causes are similar to the marrow failure, which include medication, lymphocyte abnormalities, and viral infection, most commonly the P19 virus. Feature include an isolated anemia, an elevated serum iron, or no erythroid precursor on bone marrow examination because it's a isolated red cell aplasia. Next slide. Okay. Now, for the last part, we have to differentiate between the various causes of macrocytic and microcytic anemia. We started with macrocytic anemia. We divide it according to the RWD, which is the red blood cell distribution, which is the differences in the in the shapes and widths of the RBCs. Any macrocytic anemia with normal RBC distribution width, اللي هي RDW, is probably caused by marrow failure, like a plastic anemia or myelodysplasia. Those with high RDW is most probably caused by autoimmune hemolysis or called agglutinin followed or vitamin B12 deficiency, because of the variability of the availability of the B12 and folate during the synthesis of the RBC, leading to different sizes of an RBCs. In regard to microcytic anemia, it's well known that the most common cause are the anemia of iron deficiency anemia, anemia of chronic disease, and thalassemia minor. Although sideroblastic anemia can also present with microcytosis. Next slide, please. Okay. Finally, we have the differential diagnosis anemia, which is caused by hemolysis. Hemolysis might be caused by a variety of reasons. First of all, we can have hereditary disorder. The hereditary disorder is most probably a deficiency of enzymes or membrane defects, such as hereditary spherocytosis, the G6PD deficiency, and hemoglobin synthesis abnormalities. Those are all hereditary disorder and present with hemolysis. Acquired disorders are either immune related with from RBC infection like malaria or others, autoantibodies ولا alloantibodies during transfusion, and autoantibodies like collagen vascular diseases. In the non-immune related, including mechanical damage from like a heart valve burns or membrane abnormalities like paroxysmal nocturnal hemoglobinemia. Finally, autoimmune hemolysis is the most common hemolytic anemia in older adults. Next slide, please. Okay. With regards to blood loss, anemia in older adults should generally trigger consideration of blood loss from GI or GU tract, because older adults tend to have might be caused by different variety of causes, but the most concerning part, it might be the initial presentation of malignancy in the GI tract or in the GU tract. Okay, typical findings include, because we have an ongoing blood loss, we have a low serum iron, low serum ferritin, high total iron binding capacity, as the body is trying to capture most of the iron found and reflecting absence of iron stress. Sorry. The cause of anemia blood loss include medication, include gastritis, because older adults tend to have pain syndromes in osteoarthritis, and with chronic use of NSAID may have gastritis leading to chronic blood loss, angiodysplasia, and benign tumor. All are common cause and should be considered, as we said, as well as malignancy. Also, frail patient with contraindication to invasive procedure might benefit from advanced imaging, because in evaluation of iron deficiency anemia, we might need endoscopy or colonoscopy, and this can be a little bit difficult in frail elderly patients. Next slide. Okay. That's it for me. Dr. Reem will continue from here. Thank you so much.
Thank you so much, Dr. Jaffer. That was a really informative piece. Hi, everybody. My name is Reem Ibrahim, and I'm a graduate from the University of Khartoum. And today I'll be talking about platelet-related and coagulation disorders, or basically the platelet-related part. Dr. Muram, next slide, please. So we'll begin with an introduction. So what they're bleeding diatheses that are uncommon in older adults, but they may pose a serious threat. So they could have great adverse effects, or they could lead to death, for example. There are two types of bleeding. You could have mucocutaneous bleeding, and that's usually associated with a platelet problem, whether that be quantitative or qualitative. And there's also a type of bleeding where you bleed into tissues or you bleed into joints, but that's more typical of coagulation disorders rather than platelet-related abnormalities. Next slide, please. So first, we're going to talk about thrombocytopenia. And what thrombocytopenia means is that there's a low amount of platelets. So usually whenever I have a medical problem, I would like to go about it from the basics. So thrombocytopenia, it means low platelets. So that means either I'm not making enough platelets or I'm breaking more platelets than I should be. So it's usually multifactorial in older patients because, as we know, they probably have a lot of complex medical diseases. So when a platelet count is low, we should first rule out life-threatening causes. And those could be summarized in microangiopathic hemolytic anemia. So that would be DIC, which is disseminated intravascular coagulation, thrombotic thrombocytopenic purpura, TTP, hemolytic uremic syndrome, HUS, or heparin-induced thrombocytopenia with patients who have been on heparin. There's also another cause for thrombocytopenia, which may be that I'm not counting properly. And sometimes platelets tend to clump together. So whenever the lab person is trying to count the platelets, they would form a clump and he would count them as one. But in fact, there are a lot of platelets. They're just clumped together. So in order to avoid this phenomenon, which is called pseudothrombocytopenia, we try to draw the blood and put them in edited tubes that have heparin or citrate blood, or citrate, sorry, in the blood tube to not allow the platelets to clump. Okay, next slide. First, we're going to talk about DIC. And if you've ever taken your steps, it could also be known as a consumptive coagulopathy, which means that you have basically coagulation and bleeding at the same time. So it's a very life-threatening, disease because there's a lot going on. And basically they're opposite, whatever's happening is opposite to each other, but they're still happening at the same time. It's commonly associated with severe infections or disseminated cancer. So if you have late stages of cancer, you're more likely to get DIC. And basically you present with intravascular hemolysis and a consumptive coagulopathy. Consumptive coagulopathy means the fact that you're over-consuming your coagulation factors. So you're making thrombosis, but there's also hemolysis at the same time. There are signs, let's say red cell fragmentation, thrombocytopenia, because you're also breaking platelets as well. Hemosideruria, which means after hemolysis, the hemosiderin starts to come out in the urine. There's also prolonged prothrombin and partial thromboplastin times, because like I said, coagulation factors are being consumed, which means that there's not enough coagulation happening, so i.e. bleeding. So these times would be prolonged. How you would approach DIC is you need to understand why it's happening in the first place. So what's the cause of DIC? And you need to treat that or try to manage that for as best as you can. You also need to provide blood product support because it's a consumptive coagulopathy and there's intravascular hemolysis and there's thrombocytopenia. You could give fresh frozen plasma. You could give cryoprecipitate. That's if the fibrinogen is less than 100. You could also give RBCs. That was actually one of my questions on step 2, because I had a patient with DIC and I had to give him RBCs. Next slide, please. Next, we're going to talk about TTP and HUS. And in the clinical setting, TTP and HUS are really hard to differentiate because they're basically the same thing, but they're with TTP, there is extra neurological symptoms and probably a worse renal involvement, while as HUS, there's renal involvement. But the major thing that they often become both in the same thing is microangiopathic hemolysis, thrombocytopenia, and the renal involvement. TTP is different in that there's confusion and sometimes there's also fever as well. So HUS is a triad, TTP is a pentad. So that would be microangiopathic hemolysis, thrombocytopenia, renal involvement. That's the HUS triad. With TTP, you add confusion or neurological symptoms and fever as well. The initial treatment is the same, just because it's really hard to differentiate them. You give supportive care and you also give FFPs or cryoprecipitate. TTP is slightly different as it would respond to a plasma exchange. So that means if you're changing the plasma, whereas HUS is relatively unresponsive to that. Next slide, please. Okay, next thing we're going to talk about is the heparin-induced thrombocytopenia. So whenever there's, let's say your patient is hospitalized and he was put on heparin, and then suddenly you find like bruising, or suddenly the platelet count decreased by more than 50%, that means there's something going on. And what happens basically is that antibodies bind to the complexes of heparin and platelet factor 4. And basically this triggers like a massive platelet activation. So platelets are overactivated. They're causing like thrombosis. It's just a whole lot of problems. And how you would diagnose it would be through a serotonin release assay. It's a test. But also there's a tool. It's called the heparin something like that. I forgot its name, but it's a tool that would say if is your patient more likely to have HIT or no. It is a medical emergency and patients should require prompt treatment. You need to stop the heparin immediately, and you need to start with direct thrombin inhibitors to basically counteract. So that would be any of the two drugs. It can be argatroban or it can be fondaparinux. Okay, so next slide, please. Next, I'm going to talk about ITP. And ITP is a diagnosis of exclusion, because normally whenever you talk about idiopathic, it means that I have no cause. So I need to exclude all the causes, and then I can say it's idiopathic. So it's usually a diagnosis of exclusion. Symptomatic patients are treated with IV immunoglobulins or a steroid taper because it's idiopathic and it's probably autoimmune. So you could try to treat that with IVIGs. However, unsuccessful treatments, you could try do one of the followings. You could do a splenectomy because, like I said, spleen is responsible for breaking down the platelets. You could take that away and it would be less breakdown, I guess. You could also do chemotherapy, danazol, rituximab. There's also a thrombopoietin receptor agonist, which means the agonist would latch onto the receptor and cause more platelets to be, produced. So that's ITP. Next slide, please. We're finished with thrombocytopenia, and the opposite of thrombocytopenia is thrombocytosis. And like I said, whenever you approach something, you should go back to the basics. Thrombocytosis means there's a lot of platelets. So it's either I'm producing more platelets than I should, or I'm not breaking enough platelets like I should. So there are a couple of reasons for thrombocytosis. You could go either primary or secondary. Primary means that the problem is me. And secondary means there's a secondary cause to the thrombocytosis. The most common cause of thrombocytosis is reactive, or we call it reactive thrombocytosis. It could be triggered by an infection, inflammation, or a bone marrow problem, like I'm causing extra platelets to be produced. First, we're going to talk about essential thrombocythemia, and it's basically a myeloid proliferative neoplasm. You could have multiple mutations, either JAK2, CALR, or MPL. And basically what happens is that your bone marrow is producing a lot of platelets. That's just basically it. And how you would diagnose it would be through a bone marrow biopsy. And depending on the age or your clinical presentation, you probably would need a cytoreductive drug therapy or aspirin, just because a lot of platelets is also not good. A lot of platelets means extra coagulation, means extra clots, and that's not good. So probably you would need a cytoreductive drug to decrease the amount of platelets, as well as aspirin to reduce any thrombotic events. Another cause would be splenectomy. Like I said, if you want to treat a lot of breaking down, remove the spleen. But if you remove the spleen and there's not enough breaking down, you end up with thrombocytosis. So these are some of the causes. Next slide, please, Dr. Muram. Now, previously we were talking about quantitative platelet problems, which means the numbers. So we talked about low platelets and we talked about a higher number of platelets. Now we're going to talk about the quality. So basically platelets, they trigger the coagulation cascade and they clump together to form a clot. So when you have a problem with the platelet function themselves, although it's uncommon, it can cause bleeding just because there's not any coagulation happening on time. And there could be hereditary disorders like Bernard-Solier syndrome or Glanzmann thrombocythemia, if I said that correctly. What basically that means is that platelets to platelets, when they come to clump together, there are receptors. And these receptors link together. And then when you don't have these receptors, your platelets are not able to link together and they're not able to clump. That's why you have a platelet function disorder. However, the most common acquired disorder, if you don't have like any hereditary problems, would be aspirin or a non-aspirin NSAID. Aspirin causes these platelets not just to stick together. That's why people who have a higher tendency to clot would take aspirin, just because it would help with these receptors and the platelets would not clump together. You could also do a platelet function test. That would help determine the underlying problem. It would help determine the underlying cause as to why that is happening. But nonetheless, it's a rare occasion and it's uncommon. But like I said, because geriatric patients are, they're more susceptible to adverse effects. They're more susceptible to like an extreme reaction to whatever's happening. So we always try to be very careful with them. I believe this is where I end and Dr. Muram will be taking over. Thank you so much.
Thank you, Dr. Reem. Thank you. So I will start from there. Again, this is Dr. Muram. We will talk about clotting disorder. So what the cause of the clotting disorder? There is acquired causes and conditions such as the antiphospholipid syndrome, cancer, trauma, or even surgery. And we have also inherited disorder can cause the clotting disorder, such as the prothrombin gene mutation, protein C and S deficiency, factor V lydine. So for the antithrombin deficiency, it's acquired and inherited clotting disorder. So it's caused by defect in inhibiting thrombin and activated for factors 10 and 9. So it can be acquired or inherited clotting disorder. And it's result in the hypercoagulable condition. For the most thrombotic event in the older adult are provoked and required a limited period of the anticoagulation. So the chest antithrombotic therapy for the venous thrombosis disease guideline and expert panel report is a good reference for length treatment and choice of agent. But what we have to do, if the cause is unprofit in the older patient or unexplained recurrent prothrombotic event. In this case, we have to perform lab testing for inherited clotting disorder. And up to 10% of the selected octogenarians with the recurrent clots have mutation. So you will find mutation. So right now I will talk about the bleeding disorder. So in the older adult, bleeding disorder are commonly acquired. So it's associated most of the time with the liver disease or clotting factor deficiency. The von Willebrand disease is one of the most common bleeding disorder in the older adults. Also, in the older adult, may acquire circulating clotting factor inhibitors and even present with the hemophilia. In this case, the inhibitor to factor, sorry about that. Inhibitor to factor 8 is the most common causes. The onset is often sudden, and the patient presents with significant bleeding in the soft tissue, including muscles. But we have to make difference from the hemoarthrosis event that associated with the hemophilia, with the congenital hemophilia. So the treatment in this case involved factor replacement. So also the bleeding disorder can caused by deficiency of the vitamin K dependent clotting factor. And this common occur in the older adult with the major illness. The common causes for this vitamin K deficiency is disorder of the hepatobiliary tree, antibiotic that neutralize the bowel bacteria, and the bowel bacteria is the major source of vitamin K. Or even if we have malabsorption, and last thing, if we have severe malnutrition. So the defect or deficiency in the vitamin K is treated by the oral or intravenous vitamin K replacement. So for patients who need warfarin reversal, they should also receive vitamin K replacement. The subcutaneous administration of the vitamin K is discouraged because it's the slower time of the correction and also prolonged INR and variable absorption. In the situation that the patient receiving warfarin who have severe bleeding and unable to receive fresh frozen plasma, on this we need to urgent reversal. So we have to consider 4-factor prothrombin complex concentrate and also 3-factor prothrombin complex concentrate recombinate with the activated factor 7A. So thank you. From there, Dr. Sara will be continue.
Thank you so much, Dr. Muram, and my colleagues for their great presentation. Hello, everyone. Hello, Dr. Nader. I'm going to talk about myeloid hematologic malignancies. Next slide, please, Dr. Muram.
Okay. Do you want me to share your other?
Yes, please.
Okay.
Yes, the other.
Okay, just hold a second, please. I
Okay.
will open it now.
Okay. Dr. Muram, I can continue from the same presentation, and I just added some. Okay.
Can you see the screen right now?
Yes, I can. Thank you so much.
Okay. Yeah, go ahead.
Okay. I'm gonna talk about myeloid hematologic malignancies. Actually, myeloid hematologic malignancies are a very important spectrum of malignancies to talk about because they are among the most common malignancies in older adults. They include acute myeloid leukemias, myelodysplastic syndromes, and myeloproliferative neoplasms, combined myelodysplastic and myeloproliferative disorders. The most serious complications of these malignancies is transformation to acute myeloid leukemias, especially as regard MDS and MBN. Next slide, please. This is the international consensus classification of myeloid neoplasms and acute leukemias that classified myeloid neoplasms into acute myeloid leukemia, myelodysplastic syndromes, myeloproliferative neoplasms, and mastocytosis, MDS, MBN overlap syndromes, myeloid neoplasms with germline predisposition, and finally myeloid and lymphoid neoplasms with eosinophilia and rearrangement of certain gene mutations like platelet-derived growth factor receptor A and platelet-derived growth factor receptor B. Next slide, please. We will talk briefly about the two most prevalent disorders of myeloid hematologic malignancies. The first topic is myelodysplastic syndromes, which are very heterogeneous collection of stem cell disorders that characterized mainly by ineffective hematopoiesis and dysplasia and hypercellular bone marrow, along with peripheral blood cytopenias, and that occur mostly in older adults. And patients in this case presented with symptoms of cytopenias like anemic symptoms, exertional dyspnea and easy fatigability, tachycardia and palpitations, also bleeding tendency secondary to thrombocytopenia, and recurrent infections secondary to leukopenia. The WHO classified the myelodysplastic syndromes into MDS with single or multilineage dysplasia, MDS with ringed sideroblasts, 5q syndrome with cytogenetic abnormality, MDS with excess blasts, and MDS unclassified. And this is according to the degree of cytopenia, the percentage of blast cells, and dysplasia in the bone marrow, and the cytogenetic abnormality. As regard the cause of MDS, mostly MDS are idiopathic without a definite underlying cause, but secondary MDS results from chemotherapy or radiation or chemical exposure can also happen. The choice of treatment of MDS depends on the degree of cytopenia and the need for blood transfusion and the risk of progression to AML. So the most appropriate and potentially curative option available is the allogeneic hematopoietic stem cell transplantation, but it's not the best option for older patients due to their multiple comorbidities. So other hypomethylating agents like azacitidine and decitabine and chemotherapeutic agents decrease the transfusion dependence and the risk of conversion to AML in high-risk patients, while in low-risk patients, like patients who have 5q cytogenetic abnormalities, can be treated by immunomodulatory agents like lenalidomide. And of course, referral to a hematologist for comprehensive evaluation and follow-up during the disease course is a must. The second group of disorders is myeloproliferative neoplasms, which are a group of colonal stem cell disorders with similar features that results in overproduction of functional and mature differentiated myeloid elements. Next slide, please. Next slide, Dr. Muram. The WHO further classified the myeloproliferative neoplasms into BCR-ABL positive. BCR-ABL is the Philadelphia chromosome, which we are going to talk about a few slides later. And this is diagnostic for chronic myeloid leukemia or CML. And the BCR-ABL negative myeloproliferative neoplasms, which includes the three most common essential thrombocythemia and polycythemia vera and myelofibrosis, which are called the classical MBN, as they share the same genetic mutation, which is JAK2 mutation, and other disorders like chronic neutrophilic leukemia and chronic eosinophilic leukemia not otherwise specified, and MBN unclassified. Next slide, please. The hallmark of myeloproliferative neoplasms is colonial hematopoiesis driven by acquired somatic mutations in the myeloid progenitor cells, in particular mutation in the JAK2 or Janus kinase 2, CALR, which is calreticulin, and MBL genes. These lead to constitutive activation of the intracellular JAK-STAT pathway that lead to overproduction of erythrocytes, so development of polycythemia vera, or overproduction of platelets that lead to essential thrombocythemia, and so on. JAK2 V617F mutation detected in 95% of patients with polycythemia vera, while detected in only 50% of essential thrombocythemia and primary myelofibrosis. CALR and MBL are mutated in most remaining patients with essential thrombocythemia and primary myelofibrosis. Triple negative patients which have negative JAK2 and CALR and MBL mutation, this includes a small and minor part of patients with essential thrombocythemia and primary myelofibrosis cases. Next slide, please. The cytogenetics of CML is characterized by the most famous Philadelphia chromosome that includes a reciprocal translocation between the long arm of chromosome 22 and chromosome 9, which is diagnostic for CML. These translocation lead to formation of the BCR-ABL fusion gene that leads to activation of the tyrosine kinase activity, which is very important because it's the main mechanism of action of the drugs used for treatment of CML, which are the group of tyrosine kinase inhibitors. Next slide, please. And this is a diaphragmatic illustration of the Philadelphia chromosome, which there is a translocation of the ABL gene from the long arm from chromosome 9 to the long arm of chromosome 22, forming the Philadelphia chromosome or the BCR-ABL gene. Next slide, please. Actually, myeloproliferative neoplasms share common clinical manifestations and complications ranging from the patient being asymptomatic and discovered accidentally during the laboratory workup to mild symptoms like fatigue, fever, weight loss, weakness, night sweats, bony aches, and aquagenic pruritus, which means itching or burning sensation after warm shower or bath due to increased basophils and inflammatory cytokines. Patients could be presented with early satiety and abdominal pain due to splenomegaly. They also could be presented with erythromelalgia, which means intermittent red hot painful extremities, and facial plethora and ruddy complexion in cases of multiple red blood cells in cases of polycythemia vera, or multiple platelets in cases of essential thrombocythemia. Next slide, please. They could be presented with complications of these disorders like thrombosis due to abundant cells, like arterial thrombosis leading to stroke and MI. Venous thrombosis lead to deep venous thrombosis and splenic venous thrombosis and GI bleeding. Also bleeding tendency, although those patients have multiple platelet count, but actually these platelets are non-functioning or of impaired function, so they have intrinsic platelet dysfunction and also acquired von Willebrand deficiency, so they are liable for bleeding. Also, due to increased cellular turnover, they could be presented with gout, hyperuricemia, and renal colics due to renal stones. And finally, they could transform to acute myeloid leukemia that occur most frequently in myelofibrosis. Also, cases of polycythemia vera and essential thrombocytosis could be transformed into myelofibrosis along the course of the disease. Next slide, please. The laboratory workup for evaluation of MBNs include the following: complete blood count with differential and peripheral blood film with microscopic examination to determine or exclude presence of leukoerythroblastic reaction that occurred with myelofibrosis. Also, peripheral blood fluorescence in cytohybridization or reverse transcriptase BCR for BCR-ABL1. Leukocyte alkaline phosphatase score to differentiate between leukomoid reaction secondary to infection and CML. Also, serum uric acid and lactate dehydrogenase usually elevated in cases of MBN. Next slide. Peripheral blood molecular testing for genetic mutation like JAK2 and MBL and CALR mutations. Also, erythropoietin level in suspected cases of polycythemia vera usually is normal or low, while it could be elevated in other causes of polycythemia, usually secondary polycythemia, secondary due to chronic hypoxia in patients who are smokers or on high altitude, or patients who have obstructive sleep apnea. Also patients with malignant condition, malignancy elsewhere in the body, like renal cell carcinoma, hepatocellular carcinoma, and uterine fibroids. Also cerebral hemangiomas could release erythropoietin that lead to increase the serum level of erythropoietin and consequently polycythemia. So patients with polycythemia vera usually had normal or low level of erythropoietin. Also bone marrow aspirate and biopsy, and finally cytogenetic analysis of the bone marrow aspirate for Philadelphia chromosome. Next slide, please. As regard management and treatment of different myeloproliferative neoplasms, CML basically treated using tyrosine kinase inhibitors, as we previously mentioned, that target the tyrosine kinase activity of the BCR-ABL1 fusion gene, like imatinib and dasatinib. Polycythemia vera, for high-risk patients who are greater than 60 years of age and history of thrombotic complications, can be treated with therapeutic phlebotomy, low-dose aspirin to prevent the thrombotic complications, and the use of the first-line cytoreductive agents like hydroxyurea and busulfan or interferon alpha. Next slide, please, Dr. Moro. Essential thrombocythemia, as Dr. Reem mentioned, you treated using cytoreductive agents like hydroxyurea and low-dose aspirin. And finally, primary myelofibrosis is treated using ruxolitinib, which is sold under the brand name of Jakavi, which is a JAK kinase inhibitor. And in patients with high-risk disease and high potential to cure, allogenic hematopoietic stem cell transplantation is recommended, helping in reducing the symptoms related to myelofibrosis. Also, asymptomatic and low-risk patients can be managed with observation only. Patients with polycythemia vera and essential thrombocytosis that progress into primary myelofibrosis could be treated with JAK inhibitors as well. Next slide, please, Dr. Maro. And finally, to sum up our presentation for today, the hematopoietic reserve capacity of the bone marrow diminishes with advancing age. Anemia of chronic disease is commonly multifactorial. Molecular assay may help in the diagnosis of unknown anemia if standard evaluation is unrevealing. Coagulation enzyme activities increases with advancing age, increasing the risk of thrombotic events, and the aging bone marrow has a propensity to develop myeloid clones. Next slide, please. Now let's move to the last section of our presentation for today, which is the cases. And the first case is about a 72-year-old man comes to the office because of fatigue that has worsened over the past year. He has had no chest pain, no shortness of breath, no change in weight or edema. His history includes diabetes mellitus, hypertension, and hyperlipidemia. As regard medications, he's on metformin, lisinopril, and atorvastatin. His vital signs: blood pressure is 148/65, heart rate 72 beats per minute, respiratory rate is 14, and BMI is 28. His conjunctiva are pale and other findings are normal. Next slide. The laboratory findings includes hemoglobin 9 gram per deciliter and hematocrit 28%. The mean corpuscular volume is 101, and low reticulocytic count, 27,000 per microliter. The methyl malonic acid level is increased and serum homocysteine level increased as well, but he has normal white blood cell count and platelets, and creatinine, potassium level function, and thyrotropin findings are normal. The serum normal, he has serum normal folate level and vitamin B12 level, and the peripheral blood smear reveals hypersegmented neutrophils. So the question is, which one of the following is the most likely cause of the patient's anemia? Please, next slide. Does this patient have vitamin B12 deficiency or myelodysplastic syndrome or hyperhomocysteinemia or folate deficiency? Any answers? Okay, we have C. And A. Okay. Thank you so much for your participation. The correct answer is vitamin B12 deficiency. This patient has a macrocytic anemia with hypersegmented neutrophils in the peripheral blood smear that suggests a megaloblastic process secondary to vitamin B12 deficiency. Although this patient has normal serum level of vitamin B12, but actually the serum B12 level reflects the total circulating level, but it's not a reliable reflection of the cellular B12 status. So patients may have a low serum level of vitamin B12, but still have normal cellular B12 stores. So patients with macrocytic anemia with low reticulocytic count and hypersegmented neutrophils in the peripheral blood smear is highly suggestive of vitamin B12 deficiency. Myelodysplastic syndrome is not associated usually with increased serum methyl malonic acid, and also hyperhomocystinemia is a genetic disorder associated with thrombotic events, and folate deficiency is not associated with increased methyl malonic acid. So the accurate method for diagnosing vitamin B12 deficiency is increase the serum methyl malonic acid along with homocysteine level and the findings of the peripheral blood smear, which is a macrocytic anemia with hypersegmented neutrophils in the peripheral blood smear associated with low reticulocytic count. Next slide, please, Dr. Muram. The second case is about a 72-year-old woman comes to the office for routine evaluation. She feels well. Her history includes rheumatoid arthritis diagnosed 20 years ago, and she's on weekly dose of methotrexate. She feels that her arthritis is well controlled. She has normal vital signs and BMI is 21 kilogram per meter square, and she has no active synovitis. The laboratory findings, next slide, Dr. Muram. The white blood cell count normal and platelets normal. The hemoglobin, she has a hemoglobin level of 10.5 gram per deciliter. Hematocrit is 32%. The mean corpuscular volume is 82. She has normocytic anemia. The ferritin level elevated, 350, and serum iron concentration is low, 25. The total iron binding capacity is low as well, 220. The erythrocyte sedimentation rate is high, 40, and she has normal creatinine, glucose, and cytotropin levels and liver function findings. Next slide, Dr. Muram. The question is, which one of the following is the most likely cause of her anemia? Anemia of chronic inflammation or iron deficiency anemia, methotrexate toxicity, myelodysplastic syndrome? Okay, we have A. Okay. Okay. Okay, thank you so much for your answers. Yes, the right answer is A, anemia of chronic inflammation. Next slide, Dr. Muram. The correct answer is anemia of chronic inflammation. Actually, this patient has long-standing history of rheumatoid arthritis. She has elevated ESR that indicate of ongoing process of inflammation. She has low serum iron level and increased total iron binding capacity, as Dr. Gaffer mentioned in his presentation. Patient with anemia of chronic illness usually has elevated serum ferritin level and low serum iron and low total iron binding capacity and low transferrin saturation. The patients with iron deficiency anemia most probably to have low serum iron and increased total iron binding capacity. Methotrexate toxicity occurs with other symptoms and signs like hepatotoxicity and pulmonary fibrosis, mucositis. Myelodysplastic syndrome is associated with macrocytes or megaloblasts in the peripheral blood smear. Next slide, please, Dr. Muram. The last case for today is about a 78-year-old man comes to the office for routine evaluation. He states that he feels well. He had smoked 2 packs of cigarettes daily for the past 55 years. His examination includes the blood pressure elevated, 155/75 millimeter mercury, heart rate 66, and O2 saturation is 91% on room air. BMI is 32, and he has ruddiness is evident on the patient's cheeks. The laboratory finds he has hemoglobin level of 19.5 gram per deciliter. Erythropoietin level is 2, which is low, and normal white blood cells and platelet counts, and other normal metabolic panel, creatinine, glucose, and thyroid level and liver function test are normal. Next slide, Dr. Muram. The question is, which one of the following studies is the most appropriate next diagnostic step? Genetic testing, overnight sleep study, magnetic resonance imaging of the abdomen and pelvis, or bone marrow aspirate and biopsy. Okay, D, E. Any answers? Okay, we have B as well. A, okay. And B. Okay, thank you so much for your responses. The right answer is genetic testing. Next slide, Dr. Muram. Thank you so much. This patient has elevated hemoglobin level, which is 19.5, and low erythropoietin of 2 international unit per milliliter. As we previously mentioned, that patients with polycythemia usually have elevated level of hemoglobin in presence of low erythropoietin level. So we want to proceed to prove the diagnosis of polycythemia vera through genetic testing of JAK2 mutation, Janus kinase mutation, which is positive in approximately 95% of cases with polycythemia vera. Overnight sleep study could be done if we suspecting secondary polycythemia, but in this case, the erythropoietin level would be elevated. So overnight sleep study should be done to exclude obstructive sleep apnea. Also, magnetic resonance imaging of the abdomen and pelvis could be done to exclude paramalignant disorders like HCC or RCC or uterine fibroids that could secrete erythropoietin, and in this case, erythropoietin level would also be elevated, and bone marrow aspirate and biopsy can be done if we have suspecting or atypical findings like patients who have symptoms like splenomegaly, facial plethora, and hyperviscosity, while the hemoglobin level is not as much elevated. And thank you so much. That was the end of my presentation. Thank you so much, everyone. Thank you so much, Dr. Muram, for helping us sharing the screen.
Thank you so much, everyone. Great job. Right now, we will move forward for the next presentation. It's imposter phenomenon and self-confidence. The presenter, inshallah, will be Doctors Amna, Dr. Wafa, and Hadil, and also Dr. Omnia. Dr. Omnia, if you're ready, you can please share your screen. Dr. Omnia, are you there? Hello? Dr. Omnia?
Hi everyone. Hello, Dr. Nader. So I'll share screen for the second topic, which is imposter syndrome.
So are you able to share your screen?
Yeah, can you see my screen now?
Yes.
So Dr. Amna Mutasim is going to start the presentation.
السلام عليكم. وعليكم السلام.
Hello everyone. Is my voice clear? Okay. Today we'll start talking about imposter syndrome. It's a new disease for most of us while we prepare the presentation. We want to share just the most important notes or information that we'll learn. Hopefully you'll enjoy the presentation. My name is Dr. Amna, graduate from Faculty of Medicine, University of Khartoum. I will be sharing this presentation with a few of my colleagues. Okay, so we'll start by the objective. Our objective today is to review the six important.
Sorry, Dr. Amna.
Yes.
Sorry, your voice is not clear. It's cutting up.
Oh. Okay. Is it clear now? Is it better now?
Yes.
Okay. So I was saying that we will talk today about the imposter syndrome. My name is Dr. Amna Mutasim, a graduate of Faculty of Medicine, University of Khartoum. I will be doing this presentation today with a couple of my colleagues. Hope you enjoy it. Okay. First, the objectives. We will review the six most commonly reported characteristics of the imposter syndrome, describe the manifestations and the symptoms, or the most reported characteristics of the imposter syndrome. We will identify the common behavioral comorbidities that are associated with the imposter syndrome. And finally, we'll explain the importance of identifying and treating the imposter syndrome. Okay. I can go to my. Okay. We'll start by the definition. Imposter syndrome is a behavioral health phenomenon. It's described as self-doubt of intellect or skills or accomplishment among high-achieving individuals. These individuals, they cannot internalize their success and subsequently experience a pervasive feeling of self-doubt, anxiety, depression, and or apprehension of being exposed as a fraud in their work, despite verifiable and objective evidence of their successfulness. The term imposter syndrome and imposter phenomenon are used interchangeably, with the imposter syndrome gaining more frequent use in the literature. Okay. This is a chart to sort of explain the imposter syndrome. So what the assumption is among the imposter syndrome individual, what I think others know, what I know, they tend to have a self-doubt in their knowledge, their skills. They believe other people have more experience, they have more information, more knowledge than them, which in reality they have the equal amount or sometimes more knowledge about certain topics. They tend to look down on themselves. Okay, next. The history. imposter syndrome, also imposter phenomena or fraud syndrome, impostorism, and perceived fraudulence was first described in the 70s, in 1978, by Susan Ames and Pauline Rose-Clowns. It was an observation among successful women and other marginalized groups. There is a particular interest in studying this phenomenon in medicine, as there is an established relationship between the imposter syndrome and other behavioral health disorders, including burnout, depression, and anxiety, and exacerbation of other behavioral health disorders. Okay, we'll discuss this later on. The criteria. Okay, while imposter syndrome is commonly researched, experienced, and pervasive phenomenon, there is an unknown true prevalence. Currently, no formal or widely accepted medical definition exists. So there is researches regarding imposter syndrome. Till this day, there is no definitive criteria to describe the syndrome. Just an assumption or a proposed characteristic that might exist in the imposter syndrome people. Okay, despite the lack of a formal definition, there is an 6 criteria, or the original 6 criteria identified by clients that have been expanded upon since its inception. So they did more research to work on the criteria. Okay, we'll have a look at the criteria. Okay, the class definition can be summarized to the following criteria or characteristics that may or may not be present in individual with imposter syndrome. First, we have the imposter cycle, perfectionism, superheroism, etyphobia or fear of failure, denial of competence, and achieving phobia, which is failure of success. Okay. The imposter cycle. The imposter cycle occurs with when individual with imposter syndrome face an assignment, obstacle, duty, or other achievement-related task. In those with imposter syndrome, the response to this achievement-related task is generalizable into 2 broad categories. Either they over-prepare or they procrastinate. Procrastination or over preparation. In over preparation, those with imposter syndrome feel that they must work harder than others to achieve the same goal. And because of this objectively false perception, that one must put more effort, they are an imposter. Okay. The other option is procrastination. In case of procrastination, those with imposter syndrome feel that they are an imposter due to the hurried last-minute preparation, and will eventually will eventually be exposed as fraud. They have the perception that they are fraud, and they just have differentiation in their behavior. Okay. Upon completion of the task, what happens when they complete the task? There is a brief sense of success, and there is a failure to internalize this sense of success. They don't feel they have succeeded even after they complete the task. This leads to those with imposter syndrome experiencing a spectrum of fear and anxiety, fraudulence, and other pathology, leading to the next task, effectively completing the same task, the aforementioned task. Okay. Okay, this is the imposter cycle, the imposter syndrome cycle. Whenever there is a new project or task, they face an anxiety, procrastination, or over preparation. After the project has been completed, there is a brief relief and a sense of accomplishment. Then there is a rationalization. I was lucky. Somebody else would have done a better job. Which will increase their self-doubt and anxiety, feeling like a fraud, and have the cycle go on. Okay. My colleagues, Wafa Yusuf, will continue from here. The next criteria, which is perfectionism.
Thank you so much, Dr. Amna. Hello, Dr. Nadir. Hello, dear fellows. I'm Dr. Wafa Sosal, an IMG from Sudan, University of Khartoum, Faculty of Medicine. And I'll carry on the presentation from here, describing the characteristics of imposter syndrome. So the first thing that we have here is perfectionism. Perfectionism was originally described by Clance et al. As the need to be the best. This category of continuum of hyper-competitive and perfectionist behaviors that occurs when practically unattainable standards and goals are self-imposed by those with imposter syndrome. These impossible-to-reach benchmarks continually drive a detrimental positive feedback loop in those needing to be the best. This aspect of imposter syndrome can exacerbate phenomena such as work martyrdom, which when you sacrifice your interests for a falsely perceived greater good. Overgeneralizing mistakes that are perceived as a lack of ability and overly critical, non-constructive self-feedback. These behaviors, among others, can lead to the superheroism aspects of imposter syndrome. Next, we'll talk about superheroism, which is commonly reported in imposter cycle. Superheroism is intrinsically related to the need to be the best. It often presents imposter syndrome as tendency to over-prepare for tasks, just as Dr. Amna said, and just to appear more than capable of completing them. The central manifestation of this component of imposter syndrome is over-preparation, which is secondary to the above-mentioned unattainable self-imposed standards. Next, we have what we call atikiphobia, which is fear of failure. Fear of failure manifests when facing externally or internally imposed achievement-related tasks. Individuals with imposter syndrome, can you hear me clearly? Okay. Individuals with imposter syndrome experience anxiety, fear of being shamed or humiliated if they fail or do worse than appear on a particular task. Thus, they are exposed as an imposter if they were to fail. Usually, individuals with imposter syndrome tend to deny their competence and capabilities. So closely tied to perfectionism, individuals with imposter syndrome tend to discount their intelligence, experiences, skills, and natural talents. There's a propensity to internalize failure and relate success to external influence, such as, I just got this by chance, I just got this by luck. Despite evidence that the individual accomplished a particular task without these factors. Next, this is a very interesting one because people with imposter syndrome tend to fear success. Why do they fear that? So the achievement-phobia is internalization of failures as a positive feedback loop and difficulty in internalizing and recognizing their successes, as succeeding may lead to higher expectations or increased pre-existing workload. So they fear being perceived as successful and to keep up with that image. These characteristics are not completely inclusive of all manifestations of imposter syndrome, and the lack of any or all of these classically accepted characteristics doesn't exclude an individual from being affected by imposter syndrome. So these just like outlines for the condition. Now let's talk about the epidemiology. Reports regarding the epidemiology of imposter syndrome exist, but are not significant enough in breadth or depth to make meaningful statements on biostatistical factors regarding imposter syndrome on the scale of the US or worldwide. Despite this knowledge gap, based on existing studies and reports, imposter syndrome tends to be more common in females than males, and in marginalized groups, ethically and racial minorities tend to have more imposter syndrome within them. Groups with a reportedly high prevalence of imposter syndrome includes students, minority groups, and select workforce members in high pressure and high stakes settings. Imposter syndrome is highly prevalent among students in healthcare professions. For instance, one study of medical students found more than 1/4 of male students and half of female students experienced imposter syndrome. It reliably affects the well-being and quality of life of students and professionals. In a study of pharmacy students, higher class imposter phenomenon scale, which a scale that scores the imposter phenomenon, correlated with the number of hours worked per week and prior mental health treatment. This supports the conjecture that the high-pressure, high-stakes environments of undergraduate and graduate medical education and healthcare in general are environmental factors that exacerbate or uncover imposter syndrome in susceptible individuals. This is further supported by other studies regarding medical, dental, and pharmacy students, nursing, and graduate medical education. So now that we've talked about the characteristics and epidemiology, let's explore together the etiologies of this phenomena with Dr. Hadil Ahmed. Thank you.
Hello, everyone. This is Hadil Ahmed. I'm graduated from University of Khartoum Faculty of Medicine, and I will speak today about the etiology of imposter syndrome. Okay. Like many other behavioral health disorders, the etiology of imposter syndrome is likely multifactorial, despite numerous case reports and scientific and non-scientific studies in psychology, psychiatry, and sociology. There is no formal hypothesis or agreement on the etiology of imposter syndrome.
Sound volume.
Currently, the proposed etiologies can be broken down into the following. The first etiology is imposter syndrome is a standalone syndrome. The second idea is the imposter syndrome may result from any of the previously mentioned 6 factors, which all relate to a broken metacognitive processes. When we speak about the broken metacognitive process, we mean that there is an issues with the higher order thinking skills that help individuals to understand and manage their own cognitive processes. We can say also is essentially the thinking about thinking and ability to monitor, control, and plan your own mental activities. When the metacognitive process is impaired or broken, the person might struggle with several things like self-awareness, self-monitoring, and self-regulation and planning.
Mute my audio.
The second proposed etiology is it is a manifestation. Can we go back, Omnia? It's a manifestation of other comorbid mental health disorders. Also, the third idea is the imposter syndrome may be a part of a complex presentation of various mood and personality disorders. Now we will speak about the causes of imposter syndrome across the board. Imposter syndrome is more common when trying something new and feeling pressure to achieve. In 1978, there was a study about imposter syndrome. It was made by Clance and Emes, who believe that the imposter mentality is developed from factors that include gender stereotypes, early family dynamics, culture, and personality traits. Since the initial study, imposter syndrome has been identified in people of all ages, genders, backgrounds, and there is a list of contributing causes also grown. Next, please. As we see in this picture, there is a poor guy who is surrounded by his family who showing the support for him, but in the same time, they make like a burden or extra pressure on his shoulder due to the expectations. So the leading causes include first, the family dynamics, as we see in the picture, family expectations and the value of success and perfection in childhood can stay with an individual throughout their lives. The second cause is cultural expectations. Different cultures put different values on education, careers, and different definitions of success. Third cause, individual personality trait, and we mean by that especially the perfectionism. The fourth cause is the comparison, either from the people around or from the person himself. As playing the comparison game can lead to feeling down or inadequate if you are not achieving the same accomplishments at the same time or same rate as others. It used to be thought that mostly women experience imposter syndrome, but newer studies show that there is an equal prevalence of imposter syndrome, both in men and women. Now we will speak about the history findings and physical features, physical examination, I mean, of imposter syndrome. Historical and physical examination features of those with imposter syndrome may be challenging. Many history findings obtained during the exam and which also obtained during the examination or evaluation. Also, it's a part of psychiatric assessment. The findings which we might find in the patient with imposter syndrome, as we said, the imposter cycle. These people has like intellectual self-doubt, low self-esteem, feelings of fraudulence and or inadequacy, denial and or failure to internalize competencies, achievements, or successes. They have fear of both success and failures, the superheroism. They might show anxiety, depression signs, burnout, and in professional settings, they tend to practice excessive comparison to peers. Also it can be like a personality disorder, maladaptive personality. Now we'll speak about the evaluation.
Form annotate. Mute my audio.
The class imposter phenomenon scale. It's the most commonly utilized diagnostic tool. It consists of 20 Likert scaled questions. It's a questionnaire composed of 20 questions, scaled by the system Likert scaled, which is it's a scale rating used to measure opinions, attitudes, or behaviors. Range from 1 to 5 points, which with 1 is strongly disagree, and 5 points for strongly agree. In this test, it's developed to help individuals to determine whether or not they have imposter phenomenon characteristics, and if so, to what extent they are suffering. After taking the imposter test, we add together the numbers of the responses to each statement. If the total score is 40 or less, the respondent has a few imposter characteristics. If the score is between 41 and 60, the respondent has a moderate imposter phenomenon experiences. People with a score between 61 to 80 means that they are frequently has imposter feelings, and any score higher than 80 means that the respondent often has intense imposter phenomenon experiences. Higher score meaning that more frequently and seriously imposter phenomenon interferes in person's life. There's also additional skills have been created, including the Harvey imposter phenomenon scale, Young imposter scale, Larry imposter scale, and the perceived fraudulence scale. Regarding the laboratory and radiographic and other diagnostic tests, it's not usually done for everyone with suspicion of imposter syndrome, but it's subject to the case-by-case basis and basis by the evaluating clinician. These evaluations will likely have no clinical significance unless another condition is present concurrently. The other way for evaluation is informal evaluation, either by individual self-assessment or by peers and mentors assessing one another. We can use a detailed physical examination in two cases, maybe to rule out physical conditions with the psychiatric manifestations. And additionally, there are some individuals with imposter syndrome could have psychosomatic symptoms like, let's say, palpitation, sweating, breathing difficulties, and chest pain, discomfort. So the physical exam can address these symptoms. Thank you, everyone. And now Dr. Omnia will continue with the presentation.
More mute my.
Hi, everyone. Hi, Dr. Nader. It's Omnia Ahmed, a Sudanese IMG. I've graduated from the University of Khartoum, Sudan. So I'll carry on speaking about the treatment and management of imposter syndrome. So generally, the approach to treating imposter syndrome depends on the extent to which it's negatively affecting an individual's life. Medical and behavioral health interventions should be tailored to each case, and you should also pay attention to any concomitant behavioral or mental health conditions. But in general, potential strategies could include the following. So first of all, self-reflection to enhance metacognition. As the more you are aware of your own thought processes, the more you would be the more you would possibly have control over them. Of course, counseling would help, specifically cognitive behavioral therapy, CBT, and other forms of psychotherapy. Lastly, pharmacological treatment for coexisting mental health conditions is also a part of the holistic approach for the treatment of the disorder. There could also be potential future applications of pharmacological therapy for the treatment of imposter disorder, but this is still pending further research into the disorder's neurobiology and pathophysiology. The patient may also make use of gratitude exercises to shift focus towards personal achievements, because as my colleagues have mentioned earlier, that people with IS lack the ability to internalize their achievements and success. So what are the differential diagnoses for imposter syndrome? Since imposter syndrome is not formally defined in the DSM-5 and lack a consensus set of diagnostic criteria, its differential diagnosis often overlap with potential comorbidities. But nevertheless, I'm going to list some of the potential differential diagnoses for the disorder. All types of anxiety disorders, generalized anxiety disorder, social anxiety disorder, anxiety due to another medical condition, and unspecified anxiety disorders, all types of phobias, OCD, and PTSD. Depression is also one of the differential diagnoses. Other mood disorders, burnout, low self-esteem, and other personality disorders as well. So moving on to the prognosis, of course, it's difficult to provide a clear prognosis for the imposter syndrome due to lack of formal diagnostic criteria and established treatment protocols. The complications of imposter syndrome are as follows. Untreated imposter syndrome can lead to worsening of coexisting mental health conditions and may contribute to the development of additional behavioral health issues. Deterrence and patient education. Okay, we're going to talk about the prevention of the disorder. This could be achieved through patient education. Educators can play a key role in preventing imposter syndrome by reassuring students that they have earned their place in their respective schools and professional programs. And individuals should also address feelings of insecurity early on to avoid the reinforcing cycle that my colleagues have mentioned earlier, which can lead to imposter syndrome. This is particularly important for those who are underrepresented in medicine and other professional fields. So, what can we do to enhance healthcare team outcomes? The identification and management of imposter syndrome have many implications, ranging from individuals' well-being to broader societal impacts. Prevention, early intervention, and effective management of imposter syndrome could reduce its negative effects on individuals, on patients, on healthcare teams, and families. Given the existence of multiple definitions and diagnostic criteria for imposter syndrome, the development of a formally validated diagnostic tool or a DSM definition would greatly facilitate further research into its diagnosis, treatment, and prognosis. Of course, ultimately improving healthcare outcomes. Improving the diagnosis and management of imposter syndrome would likely result in enhancing team performance in healthcare settings. And this would ultimately lead to reducing costs and burdens on the healthcare system while improving patients' outcomes. Additionally, better identification and intervention strategies may also help reduce disparities among minority groups, especially in highly pressurizing academic and clinical environments. Further, future research should focus on exploring the etiology, the pathophysiology, epidemiology, and the diagnosis and management of imposter syndrome. Hopefully, this would all lead to more effective interventions. And this is the end of the presentation. Thank you, everyone.
Thank you so much. Thank you, everyone. That was really interesting topics. So we will move forward to the last topic with the Dr. Yassein Elhussein. Dr. Yassein?
Hello, yes, can you hear me?
Yes, I hear you well. Go ahead.
Okay, assalamu alaikum. First of all, thank you all for attending, and thanks Dr. Muram for moderating today's session and for the collection presented the informative and exciting topics. So my name is Yassein Elhussein. I'm a graduate of University of Jazeera in Sudan, and I'm a co-leader of Lime Group 1. And today I'm going to be presenting some technical skills, mainly how to edit images and how to do photo edits online. To be honest, I didn't prepare PowerPoint because I do believe that the most effective way of teaching or presenting this is by demonstrating a live tutorial or live demonstration. So I would just ask if I can share my screen and then I can present.
Yes, go ahead.
Okay, can you see all my screen?
Yes, we do.
Okay, so yeah, starting with, we want to learn how to edit images. So I kind of thought to present something related to the current application pathways and residency application. So I just brought up the requirement of the ERAS picture and ERAS photos for those whom are applying for the math cycle. So at least to demonstrate with that, so everyone can benefit from this, and the others whom still they're doing their steps or still want to gain some technical skills, they might also join us. So this will be really helpful for those who do not have access currently for professional studios or for professional photo editors, those who might support them in preparing their ERAS profile picture. So yeah, as we all know that there's specific requirements in each and every application, whenever you're drafting a residency application, lottery application, visa application, there's specific guidelines, specific requirement that you have to um, make sure and consider them. So speaking of which, about the ERAS, you can see on the website, on the OSIS portal and on the ERAS website as well, that the requirements as to be like, the picture has to be a GPE format and the file size must not be greater than 150 kilobyte and the dimensions must not be greater than like 2.5 by 2.5 inches. And also there's in other area, like it mentioned that it should be like facing forward and the face should be centered, looking with like specific facial expressions. And the DPI should not exceed like 150. And the DPI is an abbreviation for dots per inch, which is referring to the total number of ink droplets which a printer can produce per inch while printing an image, and that's like it's quality. It's like measuring quality, and if you increase like the dots per inch, if the DPI increases, that means you have more detailed image, like more realistic and more enhanced high quality picture. So that's the DPI. So then what we want really to know, or what we want to master today, is how to control all of these variables, like how can we convert the type of folder from GPP to PNG to PPG and to GIF and these things, and how can we manipulate and how can reduce, increase the DPI, and how can we make sure that we maintain the same respect or of ratio while editing all of this. So for that, I like brought 3 websites, which are free, of course, probably, uh, where you don't have to create an account. You can just work online, everything. So yeah, the first one is called I Love Images, like I Love IMG, and the second one is called Free IMG Candy DPI Converter, and the third one is an AI tool called Pixlr. So the first one is like the master one, where you can edit and do everything. You can compress the image, you can reduce the size of the folder, you can resize the image itself with dimensions, you can crop and manipulate the dimensions as well, and then you can convert different type of folders from GPG to PNG, GIF, PSD, and these all are type of folder that have specific requirement and specific descriptions. You can also do some photo editor and some like sort of manipulation and contrast, enhancement and things. You can also upscale the image, like enlarge the image with high resolution and maintain the same pixelarity. You can also remove background. So this website is really amazing in terms of doing a lot of tools and a lot of edits on the picture itself. So the other one, as I said, is the DPI manipulator as well. So whenever you can add the DPI, which is the resolution, you can increase, you can decrease, you can maintain the same thing. And the third one is the pixeler, which is the master one in terms of preparing the ERAS picture. So let me start with this one, and then we can go back and learn how to use the other ones. Am I clear so far? Are you following me?
Yes.
Yes.
Okay. So as I said, you don't have to have an account to use all of these websites, maybe just for this pixeler because it's like using an AI. So it gives you like it gives you like 3 trials per day. So you have to note that. And if you want to like create an account and try the premium version, you can just buy in a package of their websites. So anyway, let's try to this free online. So you have to go to pixlr.com and then you have to open the AI photo editor. You have to open one image and you have to select which picture you want to edit. So yeah, I'm gonna use this picture which I've generated through AI itself, just for personality and confidentiality. So yeah, I'm using this. I've generated it through the Microsoft design as to be like just a professional picture so that I can use it and showing you how to edit the ERAS picture. So the first thing is, as I said, you have to maintain the ratio, the size, the dimensions, the DPI, the resolution, and the file size. So on the left side, you will find this toolbar when you have access to different tools to edit. The first thing that you have to do is you have to identify the margins and the aspect, selecting the aspect. So you have to go to the crop, and then you have to select aspect. You have to enable this, and then you have to edit the width and height as the requirements. So in the ERAS picture, they said like it should be 2.5 times 3.5. So I have to write this 2.5 times 3.5. And these 2.5 times 3.5, it's also equivalent to something like it could be also like equivalent to the DPI, which is actually 2.5 inches. When you multiply it by 150, it gives you the actual dimension of the DPI 150, which is like it will be equal like 375 times 525. We will do this now. So anyway, so by maintaining the aspect, you maintain the ratio with the width and height, and then you try to select the area that you want to show on the picture. Let's say this size, because you have to show the both of the shoulders, and the face should be centered and looking forward. So let's make it like this. And then let's apply. Whenever you manipulate the borders, it will not change the ratio. It will be the same as I selected the aspect and I like freeze this option. So don't worry about manipulating it. You just have now to maintain the ratio within the same dimensions and the same proportion you want to keep. So then you will click apply. And then you will get the picture like this. The next step is, for sure, you want to change the background sometimes. You want to keep like a light gray color. You want to keep like white color. So you go to the AI tool here, filters, and then you go to this AI tool. You find background, remove background. So now you can click on this, and then you can click on remove background, and then you'll have a background removed. The next step is you can put a color, like a background color. So you have to click on this under layers to select your background color. And then you have just to select the color. Let's choose this gray, light gray. And then you have to select apply. So now you have a background with the gray, light gray color and a nice picture. The next step is to go for the crop tool, and then you have to go to image size, and then you have to change these into the DPI dimensions, which, as I said, the 2.5 multiplies by 150, it will be equal into 355, and this will be automatically changed into 525. So, and then you have to click apply, and then that's it. You get the file image edited as the requirement to be. And then you click on save. You have to select the high quality. You have to make sure that it's saved as JPG. And you have to check also that the width and the height are like 355, which equal to 2.5 times 3.5, which is 525. And then you have to press on save. And then it's downloaded here, and then you can open it normally. And now we can see it. So this is the final picture. You can manipulate the dimensions that I said. You can crop, you can zoom in, you can zoom out at the earliest. And if you want to check the final properties of the picture, also you can do that to make sure that it is as required. So go to download, and then let me just take it into this folder. And then I can show you that when you look into properties, you can see in the details that the picture is 375 times 525 pixels. And then the DPI is less than 150. And if you check the the folder size is less than 150. So this is the required picture description, and you can see it as it is. So yeah, that how we edit it, and that how we generate a perfect ERAS picture as per the requirement. So yeah, that's the first tool, and that is the first website that is very nice and very clear and very straightforward to use. The second thing is the using of the free online DPI converter, where you can just go to the imgcandy.com, and then you have to add the file, select the picture that I would like to edit. Let's use the same picture, click open, and then you can just, from the right side, you can manipulate, select which DPI you want to use. Like let's select 150, and then press on DPI converter. Then you have just to wait for a couple of seconds, and then you can download your file. So after you download your file, go check the properties. So you'll find it's like, yeah, it's 150 dpi, but it maintained the width and pixelarity and the dimensions of the original picture, because we didn't cut it, we didn't crop it, we didn't use any other tool. So this is the second website. You can do this first, and then you can use this second picture which you edited the DPI, and then transfer it into the AI for the editor, and then you can do the other edits to apply the other required things. Then let's go to the I Love IMG, where it's the third website where you can, as I said, compress the pictures. You can resize the images, you can crop the images, you can convert them. So let's try one of these. Let's compress a photo. You have to go for the tool that you want to select, and then you have to select the picture that you would like to use. Let's use the same picture that we're using. Okay. Okay, let's use this one. You have to select and you have to click on compress. So in seconds. So you can see that the image is now like 30% smaller than the original size. The original size was 130 kilobyte, and now the final size after edit is like 91 kilobyte. And if you open the picture, you will not like find big difference in the resolution. Maybe just like lower it down a little bit, but still you compress the original size so that you can upload it anywhere that you want to upload. So yeah, that's just an example of one of the tools that you can use on the I Love IMG online. You can resize, that I said, you can crop the image, you can convert it from different image type. Like you can, this is a PNG picture. Like you can see the extension is .png. You can just change it in the GPEG, you convert, and then you download in a second. And then you check, it's GPG. So yeah, straightforward, very nice, and very helpful. So yeah, you can also remove the background. You can convert it back from GPG. You can upscale the image with maintaining the ratio and the resolution. So yeah, just a recap, you can use all of these three websites to edit the images. You can just use to convert the DPI, then you can take the same picture to remove the background, and then you can go into the AI photo editor to edit the size, to maintain the ratio, to edit the DPI, and then to download the GPEG, and then you can use it anywhere in our profile picture. I think that's all for now. I'm not sure if you have any questions. I will be ready to help you and answer your question. Thank you so much for following, and I want to hand the floor to Dr. Nadir maybe to complete. Thank you so much. I will stop sharing my screen.
Thank you so much, Dr. Yassein, and all the presenters. These are great presentations. Thank you so much. Very helpful. Any questions for any of the presenters? Any of the topics? Any questions? Yeah, I'd like to ask everyone to work on your image or your photo so that you can get ready for the application. And you can use it here in the meeting. You can just add it as a background. Dr. Yassein, he has his image used as a background, and others as well. So that would be great if you can just, it's gonna be in your profile. As well as your website. So if you want to add it to your social media, whether it's ResearchGate or LinkedIn or other Facebook, you can just update your photo, because some of the programs that you're applying to might look at your presence in the web, so they will look at your LinkedIn or ResearchGate or other websites that your name might be listed. So it's better to have a good image. Thank you. Any updates, any questions, comments, suggestions, just raise your hand or jump in. I'd like to update you guys. Dr. Myra will be helping some of you who are interested in learning Spanish. She is gonna start next week, and she was not able to attend the meeting today, but from next week she will be available. I think she will do it Wednesdays, I'm not sure, every other day. So you can contact her if you are interested, Dr. Myra. Any updates as far as projects going?
Yes, Dr. Nadir. Hi, everyone.
Hello.
My name is Jifan Ahmed, and I'm an IMG from Sudan, University of Khartoum. And recently, our abstract to the NAPCRG annual meeting has been accepted for presentation. It's going to be a poster presentation, inshallah. And I would like to thank you so much, Dr. Nadir, for this opportunity. If it wasn't for you, I don't think we would have made and come up with this project. Thank you so much.
Thank you. Congratulations. This is great. So it's a big event. The NAPCREC. It's gonna be in Canada this time, but I wish you all the best. Congratulations. Any other updates? So you're gonna be working on the poster. If you have questions, let us know. Some of the seniors are working. I think we have 3 posters accepted, will be presented in NAPCREC. So if you want to check with other fellows so that you can work together on poster presentation. Thank you.
Thank you, Dr. Nadir. Definitely, we will need some help.
I will send you the names or the emails of all the people involved in the 3 projects so that you can work together. Thank you. And Dr. Adam was asking to resend the links, but I'm not sure if you can, someone send the links in the chat, that would be great. So I'd like to ask you if you have some skills in doing or creating logos. So we are working on a logo for the program, the telegeriatric research program. So if you want, you can go to the app, and if you are good with logo creation or generating a good logo, designing a logo, you can go to the app, go to add logo, and then you can add the logo that you want to. You can give it a name and maybe a description, and then you can upload the image and send it. It's gonna be submitted and it will be listed under the logos here. I found this one. It's not licensed, so we can use it for the time being. If you want to edit this one, for example, to make it better, you can download it and then edit it. As Dr. Yassein was mentioning, we can work using different tools. The PowerPoint can also be used as a simple editor for some of the shapes. This is the logo done for one of the mobile application. It was done by Dr. Amal and her group. So it could be just simple logo. I'm gonna stop sharing. Any other new ideas for new research project? Any questions, any suggestions? I know some of you are still working on new mobile application development. So if you are interested in recruiting more people, more fellows, and that would be great. So you can give them some task to do. It will show in their CV, or they can discuss that in the interview, during the interviews, I mean. If no more questions, then I'd like to thank you so much, Dr. Muram and your team. Thank you all the presenters from today's presentations. These were great ones. And I'd like to thank all the attendees from today's meeting and those who will look at the Zoom meeting recording in the future. Thank you so much. Have a wonderful day. Have a
Thank you.
wonderful wherever you are. Salam
Thank you,
alaikum.
Dr. Nader.
Thank you, Dr. Nader.
Yeah. Goodbye.
Thank you. Ahmed.
Thank you, Dr. Nader.
Thank you.
Assalamu alaikum.
Alaikum salam.